Hello, teacher nurses. It is Professor Flourish today again. Today we are going to be talking about problems of the central nervous system and specifically the brain. Before we begin, I just want to talk about some just general neurophysical examination refreshers. And like I said, just keep in mind everything we talked about in our assessment lecture while we're going through these different disorders. So just as a refresher, first thing you want to do is that general observation. So inspecting and palpating the head for any signs of trauma. Is there anything like a fractured skull, anything of that nature? Observing for facial droop. And like I said, when we go into our neurological emergency lecture, this facial droop, as well as this palpation of the head, is going to become a lot more relevant with it. Cranial nerve testing, so checking how the patient close his or her eyelids tightly as they try to open them, puff out their cheeks, anything like that. So when we go through these different problems, just try to make sure you're thinking about which cranial nerve are we testing? Because cranial nerves, when it comes to it, what we're doing is we can see that there's an issue with our cranial nerves based off of different signs and symptoms we see with these different problems. So just kind of keeping that in mind as you continue on. Your motory and sensory functions, like touch sensation, rapid movements, observing gait, observe for any tremors, bilateral grip strength, muscle strength against resistance, and then your deep tendon reflexes. So kind of keeping all these physical examination refreshers, like keeping them in mind when we look at these. Some more kind of refreshers I just want to talk about are things like your Babinski's reflex. This is the dorsal flexion of the big toe and flattening of other toes, elicited by firmly stroking the lateral aspect of the sole of the feet. So this is an abnormal finding in anyone older than the age of 2, and it indicates the presence of central nervous system disease. So it's okay for your pediatrics 2 and under. It's abnormal in anybody older than 2. Your blink reflex or corneal reflex, involuntary closure of the eyelids in response to the stimulation of the cornea. Loss of the blinking reflex indicates a dysfunction of cranial nerve 5. So that's why I said some of these reflexes, they kind of correspond with our cranial nerves. Your gag reflex, contraction of the pharyngeal muscle, tested by touching the back of the throat. Loss of a gag reflex indicates a dysfunction of cranial nerves 9 and 10. Okay, so the first disorder we are going to be talking about is Alzheimer's disease. So Alzheimer's disease is a non-reversible type of dementia that progressively develops over many years. And dementia is basically defined as multiple cognitive deficits that impair memory, can affect language, motor skills, and or abstract thinking. The percentage of dementia attributed to Alzheimer's disease ranges from about 60 to 90%. So what it really is the slow deterioration of the mind. So it's a very relentless kind of disorder. Sorry. That kind of slowly progresses over time. The framework is made up of 7 stages based off of 3 general stages. And this is just one of the theories with it, but it's the theory that we're going to kind of talk about. You've got early, mid-stage, and late stage. And it's most likely to occur in patients in their 60s and 70s. However, diagnosis can be as early as 40 years old. Characteristics are by memory loss, problems with judgment, changes in personality, and as disease progresses, severe physical decline can occur. So the Alzheimer's disease pathology, this is a very kind of just overview general. We won't get too in depth with this pathology, but what it is it's, like I said, it's the most common type of dementia, and you have these microscopic changes of the brain and your neurotransmitter abnormalities. So there's kind of just small changes that cause these cognitive issues. What I will say about Alzheimer's is the progression of Alzheimer's is different for each patient. So there's not really a universal scale for the progression. That's what I was saying earlier. So like basically the following slides kind of go over an example of one scale. So there are other scales for this. We're just kind of generally just giving like an overview of one type of scale. So in this scale, what you'll have is mild Alzheimer's or early Alzheimer's. And what they will see are things like memory lapses, losing or misplacing items, difficulty concentrating and organizing. They're still able to perform their ADLs, but they will have trouble remembering names when introduced. So it's kind of just like a, hard to get their memories in line, and just kind of, I left my keys somewhere, but it's not big memory losses. Moderate Alzheimer's or middle stage is forgetting events of one's own history. So this one's the one that it's starting to be, instead of just I forgot my keys, it's I forgot that I even bought a car back in '82. It's something along those lines where you're just forgetting these big events of your history. At this stage, they're having difficulty performing tasks that require planning and organizing. So things like paying bills, managing money becomes very difficult. They can have personality and behavioral changes and changes in their sleep patterns. With severe Alzheimer's, this is your late stage, losing ability to converse with others. Assistance is required for your ADLs. They will have incontinence, losing awareness of one's environment, and eventually loses all ability to move and can develop stupor and coma. So deaths are usually related to choking or infection because they're much more vulnerable to infection. So as you can see with these, you kind of start, like the example that I usually think about with this is like the first stage, this mild Alzheimer's. What we have here is somebody, I don't know where my keys are. I've lost my keys. The next one is this moderate middle stage of I don't even remember when I bought the car. I never bought a car. I don't even remember doing that. And this last one is basically, it gets to the point where it's, I can't even drive. I may not even know what a car is. So it's like that progressive losing of cognitive ability. So testing, they can do some imaging assessments. So brain tissue examination at autopsy is only definite diagnosis. So the only way you can like find out is once the patient has passed, to actually look at the autopsy of their brain tissue. You can do genetic testing, CT or MRI. So a lot of the stuff with Alzheimer's is it's very important for us to kind of be aware of what's going on with them. So you want to encourage patient and family to participate in support groups. Support groups are very, very helpful with the patient because they can kind of give a better understanding to both patient and family what they're going through, what we need to do. You want to avoid overstimulation. So one of the things that we always say about patients in Alzheimer's is we live in their world, basically. You're not going to try to change their thinking process. So you want to organize your care when the patient is receptive. So if your patient is getting, if you have a patient who basically goes from very, very pleasant to all of a sudden very, very upset, then what I would personally do is just wait until the patient is happy and ready to do any of the tasks that you need to do. You kind of work in their world. You want to promote consistency by placing commonly used objects in the same location. So you don't want to just suddenly be changing the room. A thing that you do want to let the family and patient know is medications do not reverse damage, but only slow further damage. So that's not going to cure their Alzheimer's. Do not reorient, because reorienting them, it's not going to help them. All it's going to do is make it more difficult for them. And like I said before, patients will have very good days and patients will have very bad days. Use simple questions. Because the more complex questions, because think about it, what we said was Alzheimer's is an issue with cognitivity. So if you're giving them something that's very complex, it's going to be very difficult for them to come to a rational decision. So it's better to keep it very simple, like, do you want a bath today? Do you want to go for a walk today? Not, how do you feel about the bath today? These are one of the few patients that we use closed-ended questionnaires opposed to that open-ended. One of the main things is to make sure to provide a safe environment. And remember, we always do the least invasive opposed to the more invasive. So you want to be frequently monitoring them. So visual checks. So honestly, if it was me and I knew that a patient had an Alzheimer's disorder or Alzheimer's disease, I would want them near the nurse's station. And that way I can keep a close eye on them. You want to keep them away from the stairs, elevators, and exits. Elopement is very big in this population because think about it. All of a sudden they can go from being here to being somewhere else, and they think that they have to leave. They are a falls risk, so making sure that you are letting everybody know that they're a falls risk. So with them, the first thing you want to do that'll just make your life a lot easier is making sure that they are somewhere close to the nurse's station, somewhere close to where you can actually view them, somewhere that you can actually see where they're at. Because with them, they're not going to be able to necessarily follow instructions as well as we would like. So giving them instructions on a call light may not be as beneficial as making sure that they're right next to you. Because like I said, it's a cognitive issue. The next disorder we're going to talk about is Parkinson's disease. This next video here, it's in Momentum, but it's a very helpful video. It kind of goes through the different aspects of Parkinson's. Okay. So just for some general information, so once again, this is our pathophysiology overview. It is a progressive neurodegenerative disorder. So that means it progressively gets worse. It can be caused by the progressive loss of dopamine-producing cells within the basal ganglia. Acetylcholine, which is our neurotransmitter, stimulates muscle movement, and dopamine has an inhibitory effect on movement. So acetylcholine is stimulating the movement, dopamine is inhibiting effect on movement. So depletion of dopamine creates an imbalance of these two neurotransmitters. The effects of unopposed acetylcholine is apparent in the tremor and abnormal spasmodic muscle movements. So basically, in a nutshell, what this is an issue with is our neurotransmitters. We have too much, acetylcholine, but not enough dopamine. So we basically have the things that's going to make us have too much muscle movement and not the things to kind of block that muscle movement. So with it, we've got our 4 cardinal symptoms. So whenever we talk about these cardinal symptoms, you do want to know these because these are the things that you're like, okay, if I see this, then I know that I'm dealing with this kind of symptom of this kind of a disease. So the first one is postural instability, which is basically the patient is unsteady and feels as if they're going to lose balance. And you can kind of see it here in this image too, where they've kind of got this like where they're moving forward almost, and it's hard to catch themselves. Because if you think about it with these symptoms, it's all about having too much acetylcholine. So if I have too much acetylcholine, my muscles are going to be moving too much. The other one is bradykinesia, which they can also have episodes of akinesia. So if we break down bradykinesia, brady means what? Slow. Kinesia means movement. So it's slow movement. And akinesia, A usually means none, kinesia means movement. So no movement. So that's where you're getting this bradykinesia. They can have that resting tremor, which is that pill rolling, muscle rigidity, so cogwheel kind of movements, ratchet movements. So it's all that kind of rigidity. Because once again, we've got all this acetylcholine, so it's kind of firing off these muscle movements, but there's nothing to regulate it. Other things that you can have is facial stare, micrographia, that's shuffling and propulsive. So it's that drive to push forward. So one of the things that you'll see a lot is the shuffling with them. And I've got a video on here as well that we'll watch in class that definitely shows that kind of where the person does a demonstration of it. And it really does look like they're kind of like a car that's trying to move forward. And it just kind of has this drive to push forward. Low monotone speech and lack of arm swing. And a lot of times they can suffer from depression. So the other thing is this image kind of portrays that mask-like facial expression, which is typical of clients who have Parkinson's disease. Like I said, this video here is very helpful in showing that kind of slow movement. Like I will take off the noise with it because I don't think the noise will actually work, but you can kind of watch it here. You can see the movement. He's explaining with it the Parkinson's movements, but let me see. Right, you see how it's kind of got this like hunched over, this cogwheel movement here. And then if you watch the shuffling of his feet, it's got that, like I said, the shuffling and provisions where he's trying to push forward almost. And it's like, I'm trying to move forward, but I can't get everything to move the way I want it to move. Now, if you look at this patient here, what is the first thing I'm going to think about? Falls risk. Yes, I'm going to be thinking about falls risk as well as the time it's going to take to complete tasks. So with these patients who have Parkinson's, if I know that it takes them this long to just walk from a relatively short amount of space, then I know that I'm going to give them extra time to perform just activities of daily living. I'm going to allow them to have that because I want to give them as much self-dependence as I can. But yeah, you can kind of see it there where, like I said, it's kind of a good example of that pushing forward. So with it, there are different stages of Parkinson's disease involvement. And yes, I do want you to kind of know these stages so that way you can better design your care. So stage 1 is unilateral shaking or tremor of one limb. So that's usually just kind of just one arm. Stage 2 is bilateral limb involvement occurs, making walking and balance difficult, mask-like face, slow shuffling gait. Stage 3 is physical movement slowed down significantly, affecting walking more, postural instability. Stage 4, tremors can decrease, but akinesia and rigidity make day-to-day life tasks more difficult. Stage 5, patient unable to stand or walk, is dependent for all care and might exhibit dementia. So the reason why I talk about these is because it can help guide the administration of care. Because if you think about it, and let's say you get a report on a patient and they say that they are stage 3 Parkinson's disease. In that case, what I would do is think to myself, okay, I should probably communicate with physical therapy. I should probably see if we can get a walker in the room if they don't have their own walker to help with the ambulation. Because if they've got that posterior instability, that's that trying to push forward. I want them to still be independent, but I want them to be able to do what they need to do. With your stage 1, that's when we're looking towards more getting that support group and trying to just get them to understand it. When we're looking at stage 5, that's when we're doing complete ADLs for the patient, because at that point, the patient's unable to stand or walk. We're doing most of their care. So just kind of keeping these in mind, especially when you're studying. So for our nursing care, one of the things is administering medication. So one of the medications we use is this combo drug, carbidopa, levodopa. So you probably talked about it in pharmacology. Basically, in a nutshell, it improves your physical manifestations of Parkinson's disease. It's a combo drug because it kind of helps it so we can actually get the medication through the blood-brain barrier, and it allows them to receive that dopamine to help with those physical manifestations. So the levodopa, levodopa is an important one with it. The other one is our anticholinergics. These control our tremors, rigidity. You want to watch for things like dry mouth, constipation, and urinary retention. So those are like 2 of the main ones we use. Like I was saying with the levodopa, what it does is it can cross the blood-brain barrier and converts to dopamine, which is that substance that's secreted in Parkinson's disease. So that's like the helpful thing, is it's actually getting up to the brain opposed to just pure dopamine giving it to them. The other thing, aside from, aside from just the medications, You also want to be able to maintain mobility and communication for as long as possible. That's why I said try to encourage them to use walkers and just making sure that you let them know why you want them to use it. Safe home environment, that's things like no loose rugs, mats, encouraging them to rest when they need to and sit down to put on their pants or shoes, and making sure that if they are exercising that they're getting adequate rest, monitoring their swallowing, and then as always, your interprofessional care. So things like speech, occupational therapy, physical therapy, and social services, making sure that we're communicating with all these services so we get the best care for our patient. All right, so the next thing we're going to be talking about is our headaches, and the ones that we're going to specifically go over today are our migraines, cluster, and tension headaches. So just as an overview of headaches, they can be acute, chronic, temporary, or life-threatening. They can affect individuals of all ages, and they can be associated with other conditions such as colds, allergies, stress, muscle tension, etc. So your primary headache has no identifiable organic cause. So these are things like our migraine, tension-like, and cluster. Our secondary headache are associated with an organic cause. So those are things like our brain tumor, our aneurysms, which warrant further investigation and medical management. So for your general care for headaches, you want to do stress management. So understanding what your triggers are. So we're going to talk about this when we get into the different types of headaches, but just making sure you understand what is my personal trigger that can cause me to have a headache. The other thing is keeping the patient to have a headache diary can be very beneficial because you can not only describe what the headache is, but things that led up to the headache. Hand hygiene, like we said, one of the things that can cause a headache are things like colds, bacterial infections. So preventing that spread of disease is very beneficial. And reviewing your other risk factors. Do you have high blood pressure? Is that causing you to have a headache? Anything of that nature. So this is probably one of my favorite pictures when it comes to headaches because it really does kind of show where these pain is going to be felt with the patient. And we'll talk about this more when we go into each of these. But for the example, for your tension headache, it almost feels like there's a band around the head that's like squeezing the head with it because it feels all that tension through there. A migraine is usually they're going to feel this pulsating numbness, like just like all on one side. Cluster headache is a sharp, almost like an ice pick pain. And it's usually around the eyes, but it just feels very like somebody's just stabbing you in the eye, basically. The first one we're going to talk about is our migraine headaches. So with your migraine headaches, and like I said, I brought this picture again, you've got your photophobia and phonophobia. Phonophobia is that sensitivity to sounds. Photophobia is that sensitivity to lights. They can have nausea and vomiting. You want to assess for their stress and anxiety and that unilateral pain, which is often behind one eye or ear. And they can be similar, manifestations are similar with each headache. So typically there'll be a similar kind of pain. There are different categories of migraines. You have the classic migraine, which has an aura with it, a common migraine that does not have an aura, and an atypical migraine. So with the classic migraine, this is the one that has an aura. So you've got different stages, and we're going to talk about staging as well when we get into seizures. But with the classic migraine that has an aura, you've got the prodromal or the initial stage of it, which is awareness of findings for hours to days before onset. So this means before the patient has even had the migraine, they'll have things like irritability, depression, sometimes they'll have food cravings, diarrhea or constipation, and frequent urination. So it's kind of giving them a clue that they're going to probably develop this, what's it called? Or they're going to develop this migraine. The aura stage develops over minutes to an hour. So that's where they can get this numbness and tingling of the mouth, lips, face, or hands, acute confusion, visual disturbances, so light flashes, bright spots, and with it, sometimes with these aura stages, they might even say that they smell something, but it kind of gives them some indication that the migraine's coming. Now, with it, some older patients may experience an aura without pain, which is called a visual migraine. The second stage is the severe incapacitating throbbing headache that intensifies over hours. So it's that throbbing headache. So when you're trying to decipher between these different types of headaches, think about how they're described. So for migraines, it's that throbbing, pulsating headache. And what they can have are things like nausea, vomiting, drowsiness, and vertigo. And then the third stage is that 40 to 72 hours, and the headache is just dull. So, just as a quick recap, you have the initial stage where all of a sudden they're getting a little bit of irritability, and this can be anywhere from hours to days before onset. Or a stage, there's some sort of thing that alerts them that a migraine's coming. It can be something like a light flash, a certain smell, anything of that nature. And they may or may not have pain depending on their age. Then the second one is when you're having that throbbing headache. And then third stage is just a dull headache. The recovery stage is recovery with pain and aura subsiding. So they're going to have things like muscle aches and contraction of the head and neck muscles, and physical activity worsens the pain. So the patient might just want to sleep. So in that recovery stage, we kind of just let them do what they want to do. And I like this picture here because it kind of gives like a very quick indication of what's happening with a migraine. You've got that, like I said, that craving, and then you've got the aura phase where they've got visual changes, the actual headache itself, and then that hangover phase, and then it's going back into no longer having the migraine. The next type of migraine is the one without an aura, which is your common migraine. So with this one, physical activity aggravates pain. So they're going to have that unilateral pulsating pain. Common manifestations are your photophobia, your nausea, and your vomiting. 4 to 72 hours, and usually occurs in the early morning during periods of stress or with premenstrual tension or fluid retention. Your atypical migraines are usually your status migraneus, which is a headache lasting more than 72 hours, migraneous infarction, which can be neurological manifestations persistent for 7 days. So neuroimaging can indicate ischemic infarction, and unclassified is they do not fit other criteria. So these atypical migraines are basically migraines that are lasting way too long. So with your intervention, focus during the headache is basically pain control. So for these ones, you want to maintain a cool, dark, quiet environment. And after we talk about our other headaches, you can kind of think about how you're going to approach these patients. So elevating the head to 30 degrees, and you can administer medications as needed. So sometimes you can offer them like a cool washcloth to put over their head to allow them to remain undisturbed while they're dealing with that headache. With them, like I said, you do not want to really give them any music or anything like that. For the most part, you just want it to be that cool, dark, quiet environment. So some of the medications for preventions, they can give things like propranolol. For mild, you can give things like NSAIDs, or you can give things to stop them from having nausea and vomiting. For severe, you're going to give them those triptan medications, which provide that vasoconstrictive effect. You can give them iragotamine preparations with caffeine to narrow off blood vessels and reduce inflammation, or isomethapine in combination with when other medications don't work. So kind of certain migraine medications to give them. For the patient themselves, for trigger avoidance and management, you want them to avoid foods with trimine. So those are any things like pickles, caffeine, so no Coke or anything like that, no coffee, beer, wine, aged cheese, artificial sweeteners, so making sure they're not having that artificial sweeteners, and foods with MSG. You want to manage anger issues and handling conflict, avoid light glare or flickering lights. And then some of the other complementary and alternative therapy are things like yoga, meditation, massage, allowing them to remain undisturbed during the episode, and applying a white washcloth during the episodes. So those are ones that are non-pharmaceutical that you can help them with. So when you're studying these headaches, just kind of think about what's going on with them and what is my role as the nurse. So for my role as the nurse with the migraine headache, I'm just going to kind of let them, like, leave them alone and let them kind of deal with their headache, let them kind of relax and try not to cause too much disturbances. So the next one is your cluster headaches. So cluster headaches are usually more common in the spring and fall. So that's right when we're in school, right? No, I'm just kidding. They're most common, or they're more common in males between 20 and 50 years of age. And risk factors, so these are your triggers for it, are things like anger outburst, anxiety and prolonged anticipation or periods of stress, excessive physical activity followed by fatigue, and altered sleep-wake cycles. So with the cluster headaches, the clinical manifestations are brief episodes of intense, unilateral, non-throbbing pain lasting 15 minutes to 3 hours that can radiate to the forehead, temple, or cheek. So once again, it's that non-throbbing. Migraines have throbbing, cluster headaches have non-throbbing. It can be described as an ice pick that is stabbing and sharpened pain, and pain typically starts around the eye or the temple, and very typical to see redness in the eyes, stuffy nose, sweating, pallor. You can have pupillary constriction, and they do not have an aura. So the patient doesn't know this is going to happen, and it just sort of happens. And usually the patient is typically restless and unable to sit quietly when experiencing the headache, which is the opposite of the migraine patient. So the migraine patient is going to want to go to a room that's dark, no lights on, washcloth over the face. Cluster headache is going to be moving all around, talking and being very verbal about this pain, typically. So treatment, you can do home oxygen therapy at 12 liters per minute for about 15 to 20 minutes at the onset of headache, which can provide relief within about 15 minutes. Medications are very similar to your migraine medications, triptans, anti-epileptics, calcium channel blockers, all things to control these headaches, and prevention strategies. So prevention strategies can be things like wearing sunglasses to reduce your light and glare, obtaining adequate rest and sleep, exercise, and that relaxation. So the next one we're going to be talking about is our tension headache. So your tension headache is the most common type of primary headache, which occurs in as many as 78% of people. It can be caused by the flexion extension injury of the neck, poor posture, or anxiety with increased clenching or grinding of teeth. So if you grind your teeth, it can cause tension through here. And it makes sense when you're looking at the location of where they're having the tension headache. My jaw is here, I'm clenching my teeth, and then it's causing that kind of pain through here. They will often complain of a band-like pain or diffusion of pain over the head. So with them, with your tension headache, they usually complain of a band, and it's kind of like almost muscle related. And tight cervical and shoulder muscles commonly accompany them. So other features of tension headaches can include a stable pattern of headaches over many months or years, family history of similar headaches, normal physical exams, headaches that are constantly triggered by hormonal cycle, specific foods, specific sensory input of lights, odors, or other typical triggers. And some of the treatment can be things like acetaminophen, aspirin, or other NSAIDs. All right, so the next thing we're going to be talking about is our seizures and epilepsy. Before we begin, I just kind of want to talk about the difference between a seizure and epilepsy. So a seizure is abnormal, sudden, excessive, uncontrolled electrical discharge of neurons within the brain that may result in a change of level of consciousness, motor, or sensory ability and or behavior. So a seizure can just be caused by many different things. Epilepsy is a chronic disorder in which repeated unprovoked seizure activity occurs. So your diagnosis typically requires 2 unprovoked seizures 24 hours apart. So if somebody comes in and they went through alcohol withdrawals and they've had multiple seizures, that does not mean that they have epilepsy. Epilepsy is that 2 unprovoked seizures that have to be at least 24 hours apart. So some of your risk factors for seizures, you can have genetic predisposition. So absent seizures are more common in children and tend to occur in families. Acute febrile state, so particularly among infants and children younger than the age of 2. Head trauma can be early or late onset, up to about 9 months, and incidence is increased when the head trauma includes skull fracture. Cerebral edema, so this is especially when it occurs acutely and seizure activity tends to disappear when the edema is successfully treated. Abrupt stopping of AEDs. So as a rebound activity, if you suddenly stop your anti-epileptic drugs, it can cause them to have seizures. Infection, if intracranial infection is a result, it can result in increased intracranial pressure, and it can result in a potential seizure. And then if it's systematic, it can cause a seizure as well. Metabolic disorders as a result of insufficient or excessive chemicals within the brain. So things like hypoglycemia or hyponatremia, exposure to toxins, especially your pesticides, carbon monoxide, lead poisoning, anything like that. With your stroke, it most likely occurs within the first 24 hours following a stroke, which once again is that intracranial pressure. So for stroke, cerebral edema, and even your infection, it comes back to what is happening with my intracranial pressure. Is that causing me to have a seizure? Heart disease can be a common cause of new onset of seizures. Brain tumor, if it's benign, seizures are caused by that increased bulk associated with the tumor. If it's malignant, it's associated with the ability of the brain tissue to function. Hypoxia, decreased oxygen, because remember when we talked about our neuroassessment, the brain needs oxygen. If you don't have enough oxygen, it can cause potential seizures. Acute substance withdrawal, dehydration accompanies withdrawal, creating a toxic level of substance in the body. Fluid and electrolyte imbalances, which has that abnormal levels of nutrients required for our normal neurological function. So these are all different types of risk factors for it. So with seizures, because we're going to mostly talk about seizures when it comes to this, you've got different stages of seizures. You've got prodromal, early ictal oral phase, ictal period, postictal period, and interictal period. So for your prodromal, that's the period of early symptoms beginning prior to the more obvious diagnosable symptoms. So if you're thinking about this in the same way that you think about the stages of headaches, it kind of makes sense with it. Early ictal is your aura phase. That's the unique sensation that occurs prior to seizures. So that can be perception of a strange light, an unpleasant smell, nausea, or confusing thoughts for experiences or dreamlike state. Ictal period is the episode of the actual seizure. Post-ictal is your recovery phase after completion of the seizure, which can last anywhere from 5 to 30 minutes, and it's characterized by that drowsiness, confusion, nausea, that general weakness, hypertension, and headache. And an interictal period is time frame between seizures if multiple seizures occur in a short period of time. So it is important to kind of know these different stages of seizure because your patient care depends on where they're at. For example, if you have somebody that's in an ictal period, like an active period episode of a seizure, then your care is going to be a little bit different because if they're actively seizing, then you're going to want to protect them, make sure they're okay. If they're in this like early ictal aura phase, or if they're in this pre-dormal phase, then you're going to want to do things like assessing what causes their seizures, kind of preparing, making sure we're watching their ABCs, everything like that. And then if they're in the post-ictal period phase, that's just the recovery phase. So kind of getting them back to where they're at, letting them know, hey, here's where it's went on, everything of that nature. So the next thing is the types of seizures. So you've got generalized seizures, partial or focal local seizures, or unclassified or idiopathic seizures. So generalized seizures involves both cerebral hemispheres. So with these generalized seizures, it's both the right and left hemisphere of the cerebrum. It can begin with an aura, which is alteration in a vision, smell, hearing, or emotional feelings. And there's 5 different types. You have tonic-clonic, tonic by itself, clonic, myoclonic, or atonic, or achypnic. Your partial or focal local seizures involves only one cerebral hemisphere, and there's 2 types. There's complex partial seizures and simple partial seizures. Unclassified or idiopathic seizures, they do not fit in the other 2 categories. And these types of seizures can account for about half of all seizure activity and can occur for no known reason. So I like this picture here because it kind of gives you a view of the general seizure versus the focal seizure. So on the generalized seizure, it's both sides of the cerebrum, while focal is in one section. And it kind of makes sense when we see the symptoms that occur with it. So for the first one we have is the tonic-clonic seizure. So this is the one that we mostly talk about, and this is a generalized seizure. So it begins for only a few seconds with a tonic episode. So the tonic episode is that stiffening of muscles and loss of consciousness. So whenever they refer to tonic, that's stiffening of muscles. So what happens after that is a 1 to 2 minute clonic episode occurs, which is that rhythmic jerking of the extremities. So that's when you actually see that shaking body movement, which is following the tonic episode. Breathing can be stopped during the tonic phase and become irregular during the clonic phase. Biting of the cheek or tongue can occur during the clonic phase, and during the post-ictal phase, a period of confusion, sleepiness follows the seizure. So with this tonic-clonic seizure, which you can see here is we've got the tonic phase where everything is stiffening. So generalized stiffening of the body and limbs, the back is arched. So it just looks all completely stiff. Then you've got the clonic phase, which now you've got that clonic jerking of limbs and body and head. So everything's kind of jerking through here. And then in their post-ictal, they're very confused as to what just happened. So the tonic seizure is where they'll have just that stiffening of muscles. Only the tonic phase is experienced. Sorry, I think that only the tonic phase is experienced. Patient loses consciousness and experiences sudden increased muscle tone, loss of consciousness, and autonomic manifestations. So they'll have things like apnea, arrhythmias, vomiting, incontinence, salivation. Usually it lasts less than 30 seconds, but it can last several minutes. So for this one, they're only experiencing that tonic seizure. Here's another picture here where we've got where they're experiencing the tonic. So they're going to have that muscle stiffening. Then you can have clonic seizures where only the clonic, that jerking phase, is experienced. Seizure lasts several minutes and muscles contract and relax. So on here, you've got it where it's jerking. The myoclonic seizure consists of brief jerking or stiffening of the extremities and can be symmetrical or asymmetrical, and it lasts for a few seconds. So on here, you can see this picture, it's demonstrating it, where all of a sudden she's got that brief jerking here. Atonic or achypnic seizures are characterized by a few seconds in which muscle tone is lost. Seizure is followed by a period of confusion, and loss of muscle tone frequently results in falling. So on here, you can see where they've got that loss of muscle control. They slump or fall forward, head may droop. So on here, he was doing fine. He was on his phone, had an atonic seizure, and everything just kind of loops. Okay, so the next one we're going to talk about is our complex partial seizure. So these are associated with automatisms, which are behaviors the patient is unaware of. So that can be things as lip smacking or picking at clothes. They just don't know what's going on during this seizure. Can cause a loss of consciousness or blackout for several minutes, and amnesia can occur immediately prior to and after the seizure. So if you remember with these complex partial seizures, it's only happening in a certain part of the actual brain. So what they'll do is they're going to have this kind of where they might pull on something, or they might even have these olfactory hallucinations where they might smell something. But either way, they just have this impairment of the consciousness, cognitive, and affective symptoms. So like on this picture here, because I kind of like it, because it shows very upfront what it looks like. They can have this dreamy state, blank, vacant expression, deja vu, maybe even fear with it. They can even have hears music, something of that nature. The simple partial seizure, consciousness is maintained throughout simple partial seizures. So for these ones, the patient is aware of what's happening. So the difference between simple and complex is complex, the patient has that amnesia, is not aware, while in simple partial seizures, they are aware. So seizure activity can consist of unusual sensation, that sense of deja vu, autonomic abnormalities, such as that change in heart rate, abnormal flushing, unilateral abnormal extremity movements, pain, or that offensive smell. Once again, it's kind of showing another test here. So some of the testing we do is that EEG. So remembering from our assessment lecture, what consists of that, our MRI, our CT, and our CSF analysis. So with it, our nursing care, you want to obtain a history of seizure type and incidences when the patient comes in. And if you know that the patient, that you're caring for a patient who has tonic-clonic seizures, just making sure that you're aware of your ABCs. So ensuring that they've got that patent airway. Inquire about the presence of an aura. So asking them if they were aware of anything different or unusual when the seizure began, asking about those triggers. What kind of leads into it? Is there certain things that lead into it? Seizure precautions. So when the patient comes in initially, making sure you've got the padded side rails, low bed, everything like that. So on this like first section of it, you do kind of want to make sure that you're obtaining that history of seizure types and incidences. So knowing what kind of seizures the patient's going to have, knowing the presence of the aura and different triggers. So during a seizure, so these are very important things to know. Whenever there's a big list like this, you want to know. So this, in this situation, this is what the patient is currently having a seizure. So one of the things you want to do is protect the patient's privacy and the patient from harm. So moving furniture away. So what you want to do is just make sure that you're closing the door, or just make sure that there's a curtain around the patient while they're actively seizing, but moving the furniture away so they don't ram into it. Position the patient to provide a patent airway. So making sure that they are turned to the side to decrease that risk of aspiration. And then that head flexed forward. Loosen restrictive clothing. Do not attempt to restrain the patient. So do not try to tie them down. Do not attempt to open the jaw or insert airway during seizure activity. So while the patient is actively seizing, don't put anything in their mouth. This can damage teeth, lips, or tongue. Do not use padded tongue blades. Remove all pillows, raise padded side rails, document onset, duration, and seizure findings, level of consciousness, apnea, cyanosis, motor activity, incontinence prior to, during, and following the seizure. So just kind of making sure that they're not in restrictive clothes. I don't have any pillows. I've got my padded side rails up. My position is positioned to the side, And if possible, it's got that head flexed. I don't have any tongue blades around or anything of that nature. And this is just like a little helpful one of your do's and don'ts of seizure precautions. So after the seizure, once again, this is another one that you want to know. So your postictal phase of seizure episodes, you want to maintain the patient in a side-lying position to prevent aspiration and to facilitate drainage of oral secretions. You want to check your vital signs. You want to assess for any injuries, perform your neurological checks, because remember, this is after the seizure. You want to see, are they still confused? Do I need to bring them back to reality? Anything like that. You want to reorient and calm the patient who might be agitated or confused. Determine if they experience an aura, because this can help you identify the origin of seizure and determine any of the triggers. So, like I said, the first thing you want to do is like right after they've had this generalized seizure, just making sure they're in that side-lying position, because you don't want them to aspirate immediately after. So medications. So phenatonin is one of those medications that NCLEX loves to ask you about. So if I was a guessing man, I would say definitely study this medication. It's your first line seizure medication as of right now. Now this can change, but it's one of those like need to know drugs. So one of the things about it is you want to make sure that the patient takes this medication at the same time every day, because if they take it at the same time every day, then it kind of helps them regulate their seizures better. Because this goes back to pharmacology concepts, thinking about the half-life and everything. You just want to make sure you're following how to take it. It can cause gingival hyperplasia, which is that gums overgrow. So you just want to make sure that they've got good oral hygiene. So things like flossing their teeth frequently, things like massaging the gums even, just to kind of keep them regulated. It is administered with food, and pink urine may be observed during the medication excretion, so no treatment is needed for that. Whenever I'm studying medications, I just kind of like to think about what the patient would want to know. So these, I kind of like condensed it down to things that I think the patient would want to know. Phosphophenatonin is the injectable prodrug of phenatonin. So basically, when somebody's like actively seizing, that might be a medication they may give. Rampuric acid and Keppra are two of the other ones we use. Status epilepticus is repeated seizure activity within a 30-minute time frame for a single prolonged seizure lasting more than 5 minutes. So some of your complications for this can be things like decreased oxygen and inability of the brain to return to normal functioning. Usual causes can be things like substance withdrawal, sudden withdrawal from AEDs, head injury, cerebral edema, infection, metabolic disturbances. As the nurse, your action is to maintain that airway. And a lot of time when they go into status epilepticus, the drugs of choice are your PAMs, so diazepam or lorazepam, IV push, followed by that phenatonin or phosphophenatonin. So a lot of times, like I said, it's the PAMs. And if their status epilepticus gets bad enough, what they'll do is they'll give them medication to kind of, we'll go ahead and just intubate them and try to give their brain time to rest and watch that seizure activity before we extubate and everything of that nature. As always, thank you, everybody.